Hello everyone, welcome to my channel. This is a case of cataract in a 52 years old man. This patient also has a very thick arcus. So we are performing the phacoemulsification with foldable IOL implantation. We have created a main incision and the side port incision with the help of 2.8 mm keratome and used intracameral xylocaine to anesthetize the eye. The patient is under topical anesthesia. We form the anterior chamber with the help of HPMC solution, and now we are proceeding to a continuous curvilinear capsular access with the help of acetone. We have initiated the rexes at about 8 o'clock and we are rotating the capsular flap in a counterclockwise fashion. The subincisional area is a little bit tricky, and now we have an adequately sized capsular access. Express some of the viscoelastic out of the eye, which also brings the flap of the capsular access out. We perform a hydrodissection. A fluid wave goes behind the nucleus towards the opposite equator, and we rotate the nucleus to release all the cortical adhesions. Now we are performing the phacoemulsification. We have introduced the phaco tip into the eye, cleaned some of the cortical matter on the anterior aspect of the nucleus, and perform the horizontal chop to get a beautiful crack right down the middle. Then we continue rotating the nucleus in a clockwise fashion and keep chopping to get the smaller fragments, which we emulsify at the pupillary plane. The phaco settings being used for this case is a vacuum of 450 mm of mercury and an aspiration flow rate of 45. The phaco power being used for this case is 40%. Now these are the last two fragments. After getting the last fragment of the nucleus, we go for the epinuclear shell while placing the chopper in a protective position between the phaco tip and the posterior capsule, preventing any risk of a posterior capsular rent while a surge that you often get while aspirating the last piece. We are using a Simcoe cannula to aspirate the remaining cortical lens matter. We are starting in the subincisional space. I find it most efficient to get the subincisional cortex first because that is the most tricky one, and you have an adequate cushion of the remaining cortical matter to protect the posterior capsule. Then we switch to the main incision and release a small nuclear fragment that is lodged in the main incision and continue aspirating rest of the cortical matter. It is particularly important in the patients with thick arcus to keep a close eye on the nuclear fragments while you perform the phacoemulsification. A chattering of the nuclear fragments can cause some of the fragments to get lodged into the anterior chamber angle, and you might miss those fragments during the phacoemulsification and cortical aspiration, and those pieces they may cause chronic post-op uveitis and corneal edema. Now we perform the hydroimplantation, then we proceed to hydration of the side port and the main incision, get the eye to a physiological IOP, and conclude the case. Thank you very much.